Hello, good evening. So, I welcome you all to the latest webinar from Society of Pediatric Cell Therapy and Transplant. And as usual, there is another interesting and very useful clinical topic lined up today, which all transplanters face day in and day out in their practice. So, this is something which everyone is interested. So, I expect a good attendance today. And we have a lineup of a great speaker and followed by a panel discussion, which will be highly interesting. So I would invite today's chairperson, Dr. Deepa Trivedi, who is head of the Pediatric Hematology Oncology Department in Ahmedabad. And I invite her to take over today's session and chair it and introduce the speaker. Over to Dr. Deepa Trivedi. Thank you.
Thank you very much for your kind invitation. I would now like to introduce Dr. Ganesh Chaishetwar. He needs no introduction. He is a seasoned and senior BMT physician, lead consultant head at Yashoda Hospital in the Department of Hematology and BMT, High Tech City, Hyderabad. So Ganesh sir, please go ahead and start your lecture.
Thank you, madam, for the kind introduction. Good evening, everyone. I hope my slide deck is visible and I'm audible.
Yes, yes,
Yeah, thank you so
yes,
much.
sir.
So, good evening, everyone. At the outset, I would like to thank all my friends as well as the eminent pediatric transplanters from the country for this wonderful academic opportunity. And I'm genuinely grateful to be speaking to this group as IAP versus API and the adult versus pediatric group, the more academically oriented group, it's always a pleasure. And because also the reason that acute GvHD is one topic where the audience is smarter than the speaker, and that's exactly how it should be. And going through the literature, I must thank the Satya sir, Dr. Kateva, and Dr. Bhatt and Dr. Kharia, because going through the literature, it looks so exciting. Beyond GvHD prophylaxis, the therapy and the precision medicine is really coming in it. We are finally moving from how bad does it look to how dangerous is the biology, and that shift is changing the outcomes. And at the end of this slide deck, my promise today is you all will leave with a practical biology guided playbook, the how to recognize risk earlier, which is very much easily doable in our practice, how to stop waiting for the grades, and how to choose therapy by phenotype, not just by phenotype, but biomarkers and endothelium. And this is really an exciting era. So thank you to everyone for joining just 1 year, 1 day before the year end. And as we all know, there has been a phenomenal progress in GvHD prophylaxis, particularly with the advent of PTCY in 2008 and various other supportive care measures and precision medicine, even in the conditioning of allogenic stem cell transplant. This has all translated into the overall declining acute GvHD incidence, as you can see from this recent publication. The acute GvHD before 2000 used to be somewhere almost half patient used to be affected, whereas the significant grade 2 to 4 GvHD after 2010 is below 20%. Whereas in our subset of patient, again, this is ISBMT data set, there is phenomenal growth in the number of alternative donor transplant, most notably haploidentical transplant in allogenic transplant cohort. And another important thing for us is almost 95% of these alternative donor transplants, mostly haplos, are with peripheral blood as a donor source. So that's why focusing on GvHD risk becomes more important. This is the recent CIBMTER dataset. You can see GvHD related mortality below day 100 up to 4 to 6%, whereas almost 10% after day 100. So, and more so after this seminal paper in 2015, this has changed the way we look at the allogenic stem cell transplant success. So beyond the survival parameters like overall survival and disease free survival, the GvHD free relapse free survival is a new surrogate marker gazing the success of allogeneic transplant because it represents ideal recovery without any continued immunosuppression or ongoing morbidities of GvHD. So this is now becoming a new surrogate marker for the success of allogenic transplant compared to the simpler measurement of OS and DFS. And you can see in a large data set, almost 1,000 patients, whereas the overall survival at 1 year was 63%, but the meaningful quality of life maintained survival GRFS was not even half. So that is becoming of the GvHD free survival is becoming a paramount importance surrogate marker for transplant success. This is a in snapshot the GvHD and various classification based on the onset and the clinical features. So acute is those patients presenting within first 100 days of transplant, and the first episode is classical. The common skin, the organs involved are skin, GI tract, and liver. Of course, notably not just because these are the organs with high cell turnover, and because of the high cell turnover, they have high antigen presenting cells, and that's why they are the common organ involved in acute GvHD. Whereas the subsequent episodes can be labeled as recurrent, persistent, new onset, or late acute. The GvHD starting after day 100 with particular classical phenotype of the skin, mouth, and other organs, the fibrotic or the classical GvH, chronic GvH phenotype comes under classic GvH, whereas those patients who have onset below day 100 and then continuing to chronic features is overlap syndrome, and sometimes the acute GvHD also can present beyond day 100. So I'll kickstart with a case. This is a 8-year boy, high risk ALL, and this is a real life case at our center. Underwent haploidentical transplant with sister as his donor with PTCY, TAC, MMF, GvH prophylaxis backbone. He developed very early febrile neutropenia, which is common, particularly in haplotransplant. Day 1, day 2, most of the patients end up with cytokine storms, and we end up putting lot of broad spectrum antibiotics. He eventually engrafted on day 16, and he was continuously CMV negative. On day 19, he developed a diffuse erythematous rash, which is a common presentation in pediatric acute GvH patients. At this time, it was stage 3, stage 2, stage 3. And he was started on topical steroids along with 1 mg per kg methylprednisolone. Subsequently, he developed lower GI acute GvHD with 6 to 8 stools with abdominal cramps and rising stool volume despite continued steroids. And subsequently, LFT showed mild cholestasis, and the continued infectious monitoring was negative. So at this point of time, with skin as the beginning organ and subsequently lower GI involvement and progressive cholestasis. So because of the persistent thrombocytopenia, high LDH, borderline creatinine, there was also a dilemma of possible TATMA. That's common sometimes dilemma in our clinical cases presenting like this. So this has highlighted particularly the very important paradigm shift in the understanding of acute GvHD biology from the three-step model, and you can see more than 25,000 publications on acute GvHD over last almost 6 decades. The literature is much rapidly flooding of last 5 to 10 years. So compared to the classical three-step model, the conditioning related tissue injury leading to the damage associated molecular pattern, pathogen associated molecular pattern leading to location of the cytokines and inflammatory markers through the GI barrier, leading to lipopolysaccharide amplification, and then the afferent phase where host antigen presenting cell activation, donor T cell priming and expansion, and then the efferent phase, effector T cells and innate effectors in the milieu of profound cytokines and inflammatory markers leading to target organ damage in the skin, gut, liver. So this was a three-step model proposed by Ferreira et al. This is the schematic diagram, but the looking at the GvHD overall responsiveness to various interventions and various presentations, just like I highlighted in our case, there is a evolving concept of organ crosstalk through immune ecosystem. So microbiota and its diversity having an impact on overall GvHD incidence, presentation, as well as responses to various therapeutic interventions. Also, the endothelial vascular injury, which is hidden organ of GvHD, and this particularly presents with steroid resistant GvHD. And just like our case, there is always a dilemma whether the clinical criteria fits into TATMA and patient starts behaving just like TATMA with steroid refractory GvHD. Again, regulatory failure and biomarkers. This is a very upcoming promising field as the Mount Sinai International Consortium, two important markers, ST2, REG3 alpha, and this relates to treg loss, tolerance breakdown, and this is high risk category, which is most of the time steroid refractory biology. Now, coming to GvHD prophylaxis as well as management, the timeline of approvals in last 4 or 5 years, there has been a very promising molecules approved across the globe. The first is abatacept as GvHD prophylaxis in combination with CNI methotrexate for alternative donor transplants in 2021. And with regard to GvHD management, ruxolitinib was the first drug to be approved for steroid refractory acute GvHD in 2019. 2024 last year, and this year's ASH was most talked about this. Remestemcel-L is mesenchymal stem cells for pediatric patients with steroid refractory acute GvHD. And the again another important designer graft ORCA-T, which is undergoing FDA priority review, and there is a very promising literature which we will discuss in subsequent slides. So the three important additions in the GvHD prophylaxis when it was stalled with just CNI methotrexate for close to 4 decades. Just last 1 decade, the ATG, particularly in the myeloablative setting, PTCY, not just in haplo setting, but across all allogenic stem cell transplant, particularly with the publication of BMT-CT and 1703, and the new kid on the blog, abatacept, alternative donor transplants, co-stimulatory blockage molecule being approved. So this is evolving modern GvHD prophylaxis based on the type of the conditioning, donor source, and also the graft source. So you can see most notably in reduced intensity conditioning all across either PTCY or abatacept is being increasingly used, whereas in haploidentical setting, the XYOT deplete graft manipulation is also a modern and more robust GvHD prophylaxis, particularly in the pediatric subset. And this year's seminal publication by Professor Franco Locatelli, long-term follow-up with the overall survival shooting above 90% is really promising. Whereas in the myeloablative setting, again, you can see abatacept, PTCY, and ATG in matched donors as well as match unrelated donors. Whereas in haploidentical transplant, again, either PTCY or graft manipulation like XYO T cell depletion, CD45 RA, RO manipulation, and with or without ATG. So this is an evolving field. Now coming to PTCY, after the seminal paper in 2008 by Hopkins group, what actually PTCY does is in vivo, depletion of naive T cells, and it creates a T cell phenotype just like memory T cells, and thereby dampening the alloreactivity and leading to better GvHD free, relapse free survival. And this is BMT-CT and O3, a milestone paper which established PTCY as a standard of care for GvHD prophylaxis across all allo transplant setting. You can see compared to TAC methotrexate, CNI methotrexate backbone, the GRFS was much superior in the PTCY arm. Again, this was also replicated in the CIBMTR dataset. You can see almost more than 8,000 adults undergoing match-related donor allotransplant, and you can see PTCY-based backbone 2-year GRFS of 41.2% versus CNI methotrexate with or without ATG. The PTCY backbone fares much superior. So again, this year's ASH 2025 publication in the match sibling setting, you can see PTCY versus CNI methotrexate with or without ATG. This forest plot favors PTCY with hazard ratio much superior in the PTCY backbone. So PTCY is superior in on a follow-up more than 2 years, superior GvHD free relapse free survival, lower risk of acute as well as chronic GvHD requiring continued immunosuppressive therapy, lower relapse risk at 4 months, and subsequently translating into lower transplant-related mortality and better overall survival. Again, there are the sporadic papers on quadruplet GvHD prophylaxis, particularly high-risk patients. So this year we published our a small cohort of retrospective cohort of 58 patients from January 2022 to June 2025 with 12 benign and 46 malignant patients. So of course, in our subset also the GRFS at 1 year of 57.6% for a majority patients in CR2 and high-risk leukemias with NRM, the benchmark below 20%, 16.9% is acceptable. And again, acute GvHD overall 24% and grade 2 to 4 significant 12% is much promising than what it used to be before, and chronic GvHD at a shorter follow-up of 7%. So what was the remarkable finding apart from a promising reduced GvHD incidence was almost 50% patients ended up with cytokines storm, secondary HLH, requiring continued immunosuppression. That is something alarming signal out of this short cohort. So again, this year's ORCA-T is a cell therapy product designed to fit the conventional allogenic transplant center protocols. So compared to conventional transplant where you infuse the entire CD34 positive graft, in this ORCA-T product is a high precision designer graft. You do the stem cell graft processing and you infuse stem cells and Tregs on day 0 with a specified dose, and on day 2 the conventional T cells are also infused at a specified dose, 3 into 10 raised to power 6 cells per kilogram. And this is a you can see a phase 3 randomized controlled trial, and the preliminary reports at 12 months is very promising. You can see GRFS with ORCA-T product is 63% versus 31% in the conventional TAC methotrexate arm, and that has translated into better overall survival, 94% versus 83%. And what is promising is this is without any heightened infectious or other serious adverse events. And you can see on the contrary, compared to the 16% in serious infections at 1 year with TAC methotrexate, almost the infectious complications, significant infectious complications are 8.4%. Again, this very much relate to this year's Nobel felicitation in medicine to 3 legendary researchers for their discoveries concerning peripheral immune tolerance through T regulatory cells, and this is coming up in a big way. So changing gears further, again, acute GvHD staging, we all know depending upon the extent of involvement in the skin, the extent of bilirubin increment, and the volume of diarrhea with or without cramping or blood and ileus features. This is categorized, and the overall clinical grade is based on the most severe target organ involvement at the time of presentation. So skin maculopapular rash less than 25% is grade 1, 25 to 50% grade 2, more than 50% maculopapular rash grade 3, whereas generalized erythroderma more than 50% or bullous formation and desquamation more than 5% body surface area is grade 4. Now coming to liver GvHD, bilirubin 2 to 3 is grade 1, 3 to 6 is grade 2, 6 to 15, and more than 15 is grade 3, grade 4 respectively. Upper GI without the no or intermediate nausea, vomiting, anorexia, whereas persistent nausea is grade 1. And lower GI, depending upon the volume, less than 500 ml, 500 to 1 liter, 1 liter to 1.5 liter, more than 1.5 liters with or without abdominal pain, ileus or bloody stools is categorized as 1, 2, 3, 4 respectively. So again, compared to the standard MAGIC criteria, the Minnesota score is more relevant, more useful for assessing acute GvHD. The organ stages defining high risk GvHD involves percentage of involved total cohort, and this is on a large data set, combination of various organs. For example, in pediatric population, the commonest skin involvement grade 1 to 3, 50 to almost half of the children. And the second was stage 1 to 2 GI, 16%. Skin plus stage 1 GI, 13%. And the last one is stage 1 to 4 liver and skin. And you can see there is clear separation of responses by day 28 with steroids in standard risk versus high risk. And what is very promising and easily doable in our subset of practice by ELISA is this MAGIC algorithm probability devised by the American group. So you can see just two markers, ST2, the suppressor of tumorigenesis 2 and REG3 alpha, and based on the MAP score, you can see low risk 6-month NRM is less than 10%, whereas the high risk NRM exceeding 40%. So all EBMT, ASTCT 2024 onwards consensus have established biomarkers to be prognostic as well as therapeutic decision makers, but it is not universally available, and I'm sure it is going to change the scenario in GvHD prognosis, precision diagnosis, as well as precision therapy. So essentially, how these biomarkers, we all know this is a snapshot of the gut lining. So intestinal stem cells, Penneth cells, and the first involvement in the breach of gut mucosa leads to release of this ST2 crypt unit, Penneth and IC niche, and this RG REG3 alpha is a marker of crypt injury and also acute GvHD gut burden. So even though endoscopy is a great diagnostic tool about the overall topomorphology, but these markers are not just diagnostic at an earlier time point, they also are prognostic, and they also can help us devising the severity of involvement. So again, the ST3, the ST2, it attaches to IL-33 and then subsequently is released, and is a higher ST2 is a marker of steroid resistant biology and high NRM. So MAP involving the combination of these two marker measurements at various time points is non-invasive biopsy of crypt injury, and it's being utilized as the ST2 as a damage IL-3 decoy, most notably in steroid resistant GvHD. So high risk of steroid resistant acute GvHD and high NRM. REG3 alpha, again a marker of Penneth crypt injury. So high levels suggest severe gut injury, and whereas the amphoregulin, again a surrogate marker of gut GvHD, but it correlates with ST2. So either amphoregulin or ST2 alone can be used. So the symptoms show where GvHD is, but biomarkers reveals how dangerous the biology is, and that too they give us this precision earlier in timeline, so you can devise your therapeutics earlier. So this is again a Blood 2018 publication. You can see the clear segregation based on these two markers measured 7 days after starting the systemic steroids, and you can see the NRM in high risk biomarkers is 70% versus 10 to 15% in low risk biomarkers. So compared to the various clinical scores like Minnesota Clinical Risk, Ann Arbor, the composite clinical plus MAP has a better predictability as well as diagnostic and therapeutic decision making utility. So biomarkers add signal beyond clinical grade and organ stage, and this has translated, you can see, with just simple ST2 levels grade 1 to clinical GvHD, the NRM is with ST2 low is 14% versus 67% in high ST2 levels. So the under again this has been replicated and tested even in pediatric cohort, and it has found equal utility. So this has particularly given us an idea in patients who are slow responders but not at high risk. Based on these values, there is potential over treatment risk, so alarming symptoms but low biological risk, whereas patients with mild grade sometimes can have very high levels which subsequently keep on becoming progressing with more severe organ involvement, more resistant phenotype. So biomarkers enable appropriate intensity right from the beginning, and this is the landmark publication in ASTCT 2024. So again, this has been used as a prognostic, right, as a preemptive level also. So biomarker driven workflow, you can see at diagnosis draw ST2 reg3 alpha along with infectious screen, and you check the map trend at day 3 to 7, at day 7 to 14, and week 3 to 6 based on the GvHD, and based on the levels you can devise. So frontline systemic steroids, if the levels are increasing even before the advent of or onset of clinical symptoms, early escalation if the phenotype is high risk, high MAP score, and second line phenotype match based on the presentation. Again, as we discussed, based on the phenotype, if it is an inflammatory type, tocilizumab, abatacept; if it is a predominant gut phenotype, vedolizumab, and in refractory progressive gut phenotype, the fecal microbiota transplant based on as well as various cellular therapies. So this has not only prognostic value but also has a therapeutic decision making value, and also de-escalation and escalation of immunosuppression or various targeted agent based on the biology. So again, this is magic algorithm based on the two markers as well as clinical probability, and this is really changing the landscape. Of course, it is not available everywhere. There has been lot of literature, but it has not been uniformly reproducible. Of I will say not applied across the various transplant center in the Western Hemisphere. But based on the way it is being done, simple ELISA can be helpful in doing all these biomarkers in our subset, and it can really change the way we treat. And again, another important tool even before transplant, the E6 pre tool, based on a simple calculation of a formula, creatinine multiplied by LDH and divided by platelet, and if the cutoff is more than 3, this has a high propensity. These patients are at a higher risk of developing post-transplant complications, including acute GvHD, and you can see 2-year NRM at 31% in those E6 pre more than 3 versus less than 3, 12%. And it's a really prognostic and very important, insightful marker just before transplant. And these are the parameters we routinely do. So combination of these biochemical and the biomarker tools can really help us devising a better strategy in acute GvHD management. So ST2 reg3 alpha, can we prioritize biomarkers before endoscopy? Of course, yes, when the goal is prognosis as well as risk guided therapy and not just diagnosis, just like the endoscopy does, and that is in real time. So I'll quickly finish in another 7 to 8 minutes about the therapy. Steroids are the mainstay of acute GvHD treatment. Depending upon the extent of the organ involvement, you devise the dose. If it is just upper GI or extensive skin, methylprednisolone 0.5 to 1 along with the topical therapy. But if it is with lower GI, grade 2 onwards, liver grade 2 onwards, you start with methylprednisolone 2 milligram per kg along with the topical agents. Optimize the CNI, and based on the response you change. But steroids have been the mainstay of acute GvHD management for last 6 decades. But despite widespread use of steroids, many patients continue to need additional therapy, more than 50%. And it has been found that the steroid response happens in a peculiar 3 distinct patterns. Some patients who are low grade, who are initially steroid responsive, who sustain their response over time, they are a first line response with a very long term good prognosis. Whereas there are patients who have rapid steroid response, but they have subsequent on steroid taper symptom flare. These are called as second line responder. They need prolonged therapy with waxing and waning course. And the third one is refractory subtype right from the beginning. So they have severe symptoms which never respond to steroid optimally, and they are persistent with progressive severe symptoms, and these are the ones who fall into the category of fetal GvHD. So second line responsive and fetal both put together constitute more than half of the acute GvHD cohort, and this is based on the steroid response. So the first one, steroid responsive, mostly grade 1 grade 2 acute GvHD, approximate OS more than 80%. Steroid responsive, sustained response, even though grade 3 grade 4 OS still acceptable 60 to 70%, but the problem lies in steroid refractory. The OS keeps on drastically declining 30 to 40%. So first line steroids, what we know and what we ignore, we all know the standard of care, methylprednisolone 2 milligram per kg per day. The hard truth is response complete happens only in 1/3 of the patients. 2/3 either develop steroid refractory or steroid dependent, and this happens most with high grade of most notably lower gut presentation. 50% children with grade 3 4 and 35% children with grade 2 onwards. So the predictors of steroid failure at diagnosis is lower GI involvement, high ST2 at presentation, those who have early onset less than 3 weeks after stem cell infusion, and an alternative donor transplant. So in this high risk cohort, waiting for 7 to 14 days to fulfill the criteria of steroid failure or steroid refractoriness is often too late, and these are the children who keep on doing well. So these are the steroid refractory definitions based out of ASTCT. Progression after day 3 5, no improvement by day 7, or incomplete response by day 14. And in these particular subsets, the REACH2 trial has established ruxolitinib as the standard of care. Overall response rate close to 55-60%, and durable response at 2 months 40%, which has translated to improved failure-free survival. And now ruxolitinib across the group is preferred second line therapy for steroid refractory acute therapy. And this the management of acute GvHD landscape is rapidly evolving. So many targeted molecularly targeted and biologically relevant molecules. I am not going to details of these various mechanistic interventions in acute GvHD, either through ways of T cell signaling inhibitors or trafficking modulators or epigenetic modulators, IL-2 upregulators, T lymphocyte depleters, cell cycle progression halters, cellular therapies like mesenchymal stem cells, IL-6 signaling like tocilizumab, and sirolimus mTOR in IL-2 signaling. So data from REACH2, this is again a landmark GSU and NEGM publication. This is long-term sustained responses published by Moti in this JCO 2025. You can see the Rux arm, the day 28 overall response rate 63% versus best available therapy 38%, and that had been sustained at 36 months, as you can see from the curve below. So the most important thing, we start with 5 mg orally twice daily dosing, and based on the patient cell count rather than the severity, we keep on changing the dosing. Now, REM stem cell is a new breakthrough approved in acute steroid refractory acute GvHD. The dosing recommendations are 2 into 10 raised to power mesenchymal stem cells of the shell mesenchymal stem cells per kg body weight, and given twice per week for 4 consecutive weeks, and infusions should be administered at least 2 days 3 days apart. So these are the safety considerations of various targeted therapies, particularly having utility in steroid refractory acute GvHD. So again, this is another evolving newer therapeutics. The first line alpha antitrypsin product, you can see, has shown combination with corticosteroids significantly improved day 28 overall response rate, 64% versus 46%, without a very serious treatment emergent adverse event. And this was published in the tandem meeting 2025. So again, REM stem cells is, as we discussed, given 4 doses over 4 weeks, and based on the response, it can be followed up in the extension study. And these are the response rates. So overall response rate 70%, which significantly improved the day 28 overall response rate with pre-specified control value of 48%, 45%. And again, that has translated into overall survival of close to 75% at day 100 and close to 70% at day 1-2. And this has led to its FDA approval in December 2024 for all pediatric patients above age 2 months with steroid refractory acute GvHD. So the last talk, the phenotype based precision GvHD therapy. So just like our case, gut predominant GvHD, vedolizumab, which has the mechanism of action specific to gut homing blockage, and the microbiota transplants is also has utility, also with mixed results across the literature. Systemic inflammatory phenotype, inflammatory blockers like tocilizumab or abatacept, and endothelial injury phenotype where it just mimics like TMA, and here particularly the endothelial protective strategy like difibrotide can be useful. So the evolving GvHD, steroid refractory GvHD is not just an escalation therapy, it's a phenotype plus biology based. So right drug at right organ and right time can give you fetching results. So fecal microbiota mixed results, overall response rate 38%. We have more than 10 steroid refractory acute GvHD with response rate close to 70%, sustained 2 doses 1 week apart, and the response is sustained at a median follow-up of 9 months. So again, so remember this phenotype guided escalation is coming. We have to optimize not just immunosuppression, but based on the phenotype, the various therapeutic interventions. So methylprednisolone, topical steroids, supportive care. In our case, the skin improved, but gut worsened, inflammation persisted, and we had the endothelial stress signals like high LDH, persistent severe thrombocytopenia. So it is biology driven, and in this subset of patients, just intensifying immunosuppression will not be useful. So unfortunately, difibrotide is also not available for our disposal for our patients. So these are the patients who do poorly. So the next frontier, evolving areas, biomarker guided upfront therapy, AI driven GvHD prediction and early intervention, and lot of novel therapies coming up. So again, based on the phenotype and these biomarker based interventions can yield a very promising result. So modern algorithm for steroid refractory acute GvHD, of course, ruxolitinib is the backbone, but supportive care and in pediatric population, REM stem cell. So the take home message from this vast topic is acute GvHD is still a major driver of post-transplant mortality, even in the steroid era. The goal is earlier risk recognition and earlier right therapy based on the phenotype, and not stop treating just grades, start treating biology as has been highlighted through the evolving literature. Modern acute GvHD is an immune ecosystem injury, not just a three-step cytokine story as I highlighted. Biomarkers are now no longer research only, particularly two important ELISA-based biomarkers like ST2 and REC3 alpha provide actionable prognosis and actionable therapeutic intervention, avoiding both under and over treatment. So steroids remains first line, but the waiting game cost lives. So waiting for 7 days, 14 days, still labeling as steroid refractory, letting the biology to worsen further. And there are a lot of trials coming up upfront, high risk biology patients upfront, JAK1, JAK2 inhibitors, or the various novel interventions, and we should watch this space for the coming years. What is one thing which we all can take from today's talk, and we can all together lobby to get it done through our labs, is the biomarkers, which are easily doable, notably ST2 and REC3 alpha. Again, ruxolitinib is the second line anchor standard for steroid refractory acute GvHD. Phenotype guided escalation improves outcomes. Composite biology in 2026 is the direction. So these biomarkers along with the E6 pre-transplant score can sharpen our NRM prediction upfront and can guide us about the conditioning intensity, the GvHD prophylaxis, GvHD preemptive therapy, as well as the duration of therapy. Prevention is reshaping incidence. The smarter for prophylaxis, the established players like PTC by abatacept is changing the landscape. So as the prevention is better than cure, so win before GvHD becomes. And I think what we can take home today is composite biology. So the MAP score combined with E6 pre-transplant score can really help us devise the entire transplant program for a specific patients and can help us apply the precision medicine in our own cohort of patients. So with that, I thank all of you. I would like to thank all my team at Yashoda Hospital, High Tech City, Hyderabad, all my associate specialties, and most notably patients and caregivers. So wishing you all a very happy, exciting New Year 2026, particularly in the hematology, oncology, and stem cell transplant cellular therapy arena. Lot of new exciting, promising therapies, and 2026 already seems to be very exciting and happening. So thank you so much. So for this opportunity again, I will be happy to answer if there are any queries during the panel discussion.
Thank you very much, Dr. Ganesh, for that brilliant lecture in such a short time. Satya sir, do we do questions or we go to the panel?
No, we do the questions. There are a few questions in the
Okay.
chat box.
Yes. So the first question is, what is the logic of 100 days to classify acute and chronic? Should we be changing that?
So that's a great question. So the hundreds and thousands and lakhs of patients over last 7 decades, their classical presentation has been one observation. Most of the acute GvHD have their onset before day 100, and that's the logic of putting that day 100 cutoff for classification of classical acute versus classical chronic. It's just a observation over hundreds and thousands of patients over last 7 decades. I think beyond this, I don't have anything in my mind. But if anybody has any precise answer, I'll request all the experts to put their comments in this.
Yeah, so Ganesh, this is what traditionally we all have been following, but the introduction of non-myeloablative transplants and RIC transplants has changed the onset of acute GvHD. It may happen very late, like close to day 100 or even beyond. So that's why this definition is not very strictly applicable now. But traditionally, in a myeloablative transplant, this is very true. Day 100 is a good cutoff. So
Yes.
next question,
Sir,
Dr. Deepa,
sir,
you want to
for
ask?
that, I will just like to add one more comment. For that reason, ASTCT has come up with this late acute after the RIC has revolutionized the conditioning from 1997 onwards, and 2008 they have come up with this late acute as another acute subtype, acute GvHD subtype. Thank you, sir.
The second, yes, sir.
Yeah, please go ahead.
The second question was the specific day for the biomarkers, but I think that was already discussed, that you could do it at the start of GvHD and then at 3 to 7 and then 7 to 14. So that was already answered. Any Indian labs doing these biomarkers? Everybody wants to know now.
That's what I was urging and requesting all the eminent members on this August dais that we should
So,
all
Dr. Ganesh, it
lobby
is
to
not done at the
all.
moment, but it will be
That's
done.
what we should all lobby to start
No,
it done
already
for
Lal
the
pathology is Dr. Jasmeet is already she's validating it. So
yes,
Lal.
hopefully in the next 1 month or so we should
correct,
have
correct.
this. She's validating it already, so I think should be available soon.
Great.
Yes. What Sunil is saying is right. Dr. Jasmeet is going to come up with these biomarkers very soon.
Next question is, where do you place abatacept in acute GvHD?
So abatacept, as I mentioned, the phenotype-based inflammatory markers high, and the biomarkers along with those patients particularly who have high pre-transplant E6, I will keep abatacept as a tool in the progressive GvHD.
Okay.
Inflammatory
And how do you?
phenotype. Yes.
Yes. How do you treat aggressive lung GvHD?
So depends on the type of GVH manifestation. If it is BOOP, so the classical three drug regimen of azithromycin, inhaled steroids, and so it all, if it is bronchiolitis obliterans or it is progressive pulmonary fibrosis. So many of the classical GVHD, chronic GVHD setting drugs are not so effective in lung GvHD. So depending upon the phenotype, we can devise the either immunosuppression or more smarter targeted drugs.
Okay. And we have I think we don't have much time, right? We have to go to the panel.
We can take one more question last.
So there is a question. Do we really need to differentiate GvHD from endothelial injury? Does it fall in the same spectrum? I think that was discussed, TA, TMA, SOS.
So if this is a common dilemma in our practice. Many of the patients, if you start looking at, when you start thinking about it, you will get these patients. And these are the patients who are steroid refractory, and you keep on calculating the TA-TMA score. It exactly fits into TA-TMA. We don't have C5b9 as a complement cascade assay as a marker for TA-TMA. We can't do these patients kidney biopsy or any targeted organ biopsy because of persistent severe thrombocytopenia, and they exactly fit into TA-TMA. So if you look at the TA-TMA, the definition, many of the patients present initially like GvHD and subsequently evolve into TA-TMA. There are patients with acute GvHD who have steroid refractory phenotype, and eventually you end up with this classical thrombotic microangiopathy, recurrent HB-DAP, drop, persistent severe thrombocytopenia, high LDH. So phenotype exactly matches the TA-TMA. So basically these are all endotheliopathies. So see, this should be treated differently. Either the high dose steroids alone or ruxolitinib combination alone doesn't work here. So if you treat like TA-TMA, difibrotide, any endotheliopathy, they have a better outcome.
Thank you, Dr. Ganesh, for a wonderful session. And thank you, Dr. Deepa, for chairing this session. It was wonderful, wonderful. This is one of the best GvHD talks I've heard in a long time. Very crisp. So I hope everyone has enjoyed this. And the take home message was wonderful. Don't treat the grade, treat the biology. This is the future of GvHD, and this is the way we should go about it. So thank you. And now I will hand over to Dr. Sunil Bhatt to take over the next part, which is the panel discussion. Over to Sunil. Thank you.